A very good evening, dear doctors. Today we are going to conduct another great clinical episode on our XP Connect webinar education series powered by Volison Technology from G Healthcare. Today we have a pioneer in the field of diagnostic ultrasound and fetal medicine. Someone who needs no introduction. Please welcome Dr. Ashok Khurana, Chairman, the Ultrasound Lab, New Delhi. Dr. Khurana has authored 2 medical textbooks on 3D, 4D ultrasound and the other on breast ultrasound. He has contributed several articles on ultrasound in prestigious medical journals. This includes pioneering work in cancer of the uterus. Dr. Khurana is the immediate past president of the Society of Fetal Medicine. He is a member of several academic societies where he has lectured extensively, conducted training workshops, and chaired several scientific sessions. These include the ISWOG, IRI, FOXY, and several others. Before we get started, due to nationwide lockdown, there has been a huge traffic load on internet services. If you experience temporary interruption in the transmission, kindly bear with us. We will sort it out immediately and resume. Kindly do not log out and keep refreshing the screen every 30 seconds. Now I welcome Sir to address our viewers with his clinical talk on ultrasound of fetal anterior abdomen wall. Over to you, sir.
Thank you. Thank you, Zenith. And I'd like to take this chance to thank everyone at GE for making this education possible. I'd also like to thank at the outset Technology Connect VC Now, which is the company that is bringing you these webinars and ensuring that we have a minimum of interruptions. And of course, Vishal Mittal at the Society of Fetal Medicine office for always being there to make sure that there is perfect coordination and that all the troubleshooting happens appropriately. You just heard this instruction that if you find that the streaming is not appropriate, remember only to refresh your screens. You don't need to log out and log back in again. It may not work. The best thing is just about every 30 seconds, refresh the screen, and I'm sure it will be working by then. We have somebody to work on glitches all the time. And so on to this webinar for tonight, Fetal Anterior Abdominal Wall Defects. And over the next hour or so, I will take you through some very interesting features of a topic that does not receive as much attention as it should, simply because it's presumed that there's only 2 conditions sitting there. And everybody presumes that there is just omphalocele and gastroschisis and that there is nothing more to it. But that is not true. Anterior abdominal defects include a whole gamut of things, and they actually form a wide spectrum of abnormalities that allow the contents to any unusual opening in the anterior abdominal wall. And of course, in the beginning of pregnancy, which is logical, which is what happens. And anything that persists after that could be a congenital umbilical cord hernia, an omphalocele, gastroschisis, bladder exstrophy, which is quite different from cloacal exstrophy, and we will discuss that as we go along. Bodystock anomaly, which is pretty much included in this group. Prune belly, which some people include in this group, but I always like to include it because it's part of the differential diagnosis. The pentalogy of Cantrell, which is always fascinating for most people involved with imaging. And of course, abdominal schisis due to amniotic bands. And so we will take you right through all of these and talk about the imaging peculiarities and what we need to do in order to give a diagnosis that would be completely relevant to managing the fetus. Because the correct prenatal diagnosis of these anomalies with ultrasound is extremely important both for patient management and for warning the pediatric surgeon and the neonatologist that this is going to happen, also for sharing it with the family. And it is indeed unfortunate that many are incorrectly diagnosed or incompletely diagnosed. And we will emphasize some of that as we go along. Because if we diagnose these completely and correctly, we will find that we can ensure a proper management of the pregnancy, including the timing of delivery, the place of delivery, the mode of delivery, and also ensure that tertiary care is available so that the optimal outcome is available for that particular fetus. Of course, because there is such a wide variety of conditions and some of these are complex, and accurate diagnosis can be a challenge, and we can go through this evening what can be met in terms of a challenge and where we stand today. And we know that increasing awareness of the full spectrum of anterior abdominal wall defects should improve prenatal diagnostic accuracy, and this talk helps us to do that. One of the most important things that we need to do in this whole thing is to evaluate the defect relative to the umbilical cord insertion site. And that will really help us to differentiate between the various malformations. And here is a list of the clues that we need to follow. Basically, the two most common ones, of course, are gastroschisis and omphalocele. In omphalocele, we find that the cord inserts onto a membrane-covered midline defect, compared to a gastroschisis where the defect is on the right, inserting cord and free-floating bowel loops are present. Very interestingly, in cloacal exstrophy, the defect extends inferiorly and the bowel loops extrude between the two halves of the urinary bladder. In pentalogy Cantrell, the defect actually extends superiorly and is typically associated with ectopia cordix and a whole lot of other defects, which we will discuss as we go along. Remember that in bladder exstrophy, which is a lower abdominal defect, the hallmark finding is the absence of a fluid-filled bladder, and therefore looking for a bladder becomes a very important part of what is actually going on. Now, the cord insertion site in bladder exstrophy does not form part of the defect, and we will emphasize this when we come to that particular section. In Bodystock anomaly and abdominoschisis, we generally find that you can't actually define where the cord is, and the defect can be quite bizarre, and then I will show you images so that you can remember this idea as well. To put this already into the first important summary, here we go. And this is truly the most important slide, and it's taken from an article that appeared in Radiographics a few years ago, but is still completely relevant. We look at the cord insertion in relation to the abdominal wall defect, and if the cord insertion is normal, we try and see whether the defect is to the right of the cord insertion or whether we have a low defect below the cord insertion and no extruded bowel. In the first case, where the defect is to the right of cord insertion, we have a diagnosis of gastroschisis. On the other hand, if the defect is below the cord insertion and there's no bowel extruding out, then we start thinking in terms of a bladder exstrophy. If the cord insertion is abnormal, we try and see associated features. And if you have a low defect, including a cord insertion defect and absent bladder, then you start thinking in terms of a cloacal exstrophy, and this will then extend into the genitalia, and of course you won't find an anal dimple. If the cord insertion is on membrane surrounding the defect, then we know that that's a nice straightforward omphalocele, and then we looking at the associated conditions. If it is a high defect above and potentially involving the cord insertion, then we start thinking of a pentalogy of Cantrell. And if you have no defined anatomic distribution and the fetus is relatively fixed, we start thinking of amniotic bands and abdominoschisis, or a Bodystock anomaly where typically there is no free floating cord. And I promise you that at the end of this talk I will show this slide again so that we can summarize this, because truly speaking, this remains the key to forming a complete diagnosis. And remember that you do have to keep this entire list in mind when you find that tracing the abdominal wall results in something that is not right, and therefore you start thinking further. And so I will take you through a very few but irrelevant embryological considerations, a working classification for the abdominal wall defects as you've just seen, mathematics where it is relevant, including a very interesting new angle which has been described from India, and I'm very proud of my colleague who has done that. Technology and how we use it to get the right answers. Not everything is always apparent on a 2D like this, And a 3D like this might actually be more useful just for making the patient understand, for convincing the surgeon, and for a more subjective evaluation of follow-up, and therefore that might be useful, and occasionally MRI as well. And of course, we've already discussed the relevance of evaluating cord insertion. And with all of this, we will then decide how to diagnose, prognosticate, and manage this spectrum of conditions. So let's go step by step. And when we talk about embryological conditions and considerations, we're actually looking at slides like this for years. The good news is we don't need to, because we've replaced these with images that you and me now create in everyday clinics. So the bilaminar germ disc, as we used to call it, between the amnion and the yolk sac is now quite simply on 3D seen as a yolk sac separately and an embryo separately. And there is nothing to be worried about there. There is a connecting stalk, which is very short, and you can see that here. As pregnancy develops, the actual cord develops, and we know that at 9 to 10 weeks, the cord is as long as the fetus is, or the embryo as we call it at this time. And that at about 9 weeks or so, the bowel can no longer be kept inside the abdomen because it's too large, and it starts protruding into the base of the umbilical cord. And then at about 11 weeks, it is almost completely gone back, and by 12 weeks, it should have definitely gone back. If at any time there is any doubt, you can do some fancy studies with 3D and power Doppler, directional power Doppler, and a silhouette mode like seen here, and you can try and figure out the entire vascularity to try and understand what's going on. But most of the time, something like this is not required. What is reassuring is when we see something like this, a simple transvaginal scan, a quick 3D reconstruction, a little protrusion at the base here, and it looks small enough to know that, yes, if I follow this up at 12 weeks, I don't have to worry. And truly that sorts out most of the problem most of the time. You may not even have a 3D. All you have to do is to repeat a 2D at about 12 weeks plus, and most of these would go back physiologically, and therefore we don't have to be worried. The ones that don't go back are the ones that we should be able to pick up fairly early, and the vast majority now being picked up at the 11 to 14 weeks window. Do remember, of course, also that a quick transvaginal 3D reconstruction of the fetus is something you should be familiar with, simply because there's lots of clues sitting there on what to expect from a fetus. For instance, at 7 weeks, the embryo is still L-shaped. The limbs are small. The upper limb is larger than the smaller limb. The cord is relatively broad at the base compared to what we would expect at this stage. And the abdomen is relatively small. The cord base is relatively wide, but there is no bowel in it. By the time we come to about 9 weeks plus, we find, particularly if you add a bit of silhouette mode, that the base gets wider, but the fetus has grown, the embryo has grown. And finally, there is a bulge at 9 to 10 weeks, which is better seen once you start playing with shadows. And there you see a nice physiological bulge, and the vast majority of these are physiological. Some of this detail is not really available at this stage if you do a 2D ultrasound scan, but the fact remains that yes, if there is a previous history, you might want to look at this more carefully. But as long as you're familiar with what is important, that is really true. And the fact remains that the reason why I use 3D is because it truly makes appreciation of variation from norm a lot simpler. And contrary to belief that 3D is something that should be used by people who are more advanced in the field, if you do a good 3D, you can actually get more information when you're younger in the field, because it makes the job much quicker, much faster, and much more accurate. By the time, of course, we reach the 12-week window, the cord just consists of the vessels and little Wharton's jelly and nothing else, and we should be able to recognize that particular pattern. Note now how the base of the cord is much smaller compared to the rest of the entire abdomen, and this is the evolution of the cord from 7 weeks to 11 weeks. Now, how do we use this information? First of all, that if we ever have a doubt, we do a 3D, and we use our information that yes, this is a normal appearance at about 8 to 9 to 10 weeks. If I have any doubt, I run color and notice that the color occupies the entire cord and therefore there is nothing else in it. I'm happy. However, if I see a dysmorphic embryo with an abnormally formed head, which will probably turn out to be acrania if I follow this up, an almost missing lower part of the body and a bulge in the middle, then I start thinking, no, this is a problem. And if I were to see this in a non-pulsatile embryo, then I know that the cause of the pregnancy loss was truly a complex structural defect, and then I'll work it up accordingly and decide whether it's the first or the second such event or the third such event, and whether a genetic evaluation is required or not. But essentially, for excluding all the stuff that we talk about in terms of the physiological herniation of the bowel into the base of the umbilical cord, remember that it can take up to 12 weeks, 0 days to go away, that the total bulge never exceeds 10 millimeters, it never contains liver, and if you do have a doubt, just call them back at 14 weeks and you will have an answer. So there is no doubt that by 12 weeks we should be able to sort out most of these, and the odd one that doesn't get sorted out at 12 weeks, call back at 14 and don't wait until 16 weeks. Now, the only thing about embryology we need to know is that yes, there is a difference in how these evolve, and therefore they're quite different from each other. And from a surgical point of view, this becomes important. And because then the abdominal wall repair for the pediatric surgeon is different, it's important to identify a condition as one of the various conditions. So if we have a failure or migration of the lateral folds, then we will get an omphalocele. And remember that all this begins by 6 weeks and is completed by the 8th week of gestation. So at 8 weeks, 0 days, all this would be done. If there is a failure or migration of the lateral folds and the cephalic folds, we will get a pentalogy of Cantrell. And if we have a failure of migration of the lateral and the caudal folds, you will get an exstrophy of the bladder, or you will get an exstrophy of the cloaca, and then you can study that accordingly. And of course, if all three axes go completely wrong, you will get a limb-body wall complex or a Bodystock anomaly, and then you will have to see that as different. And obviously, this is the one that would be fairly impossible to repair. This would be easy to repair. This would be something that is often has a poor prognosis because of the heart itself and the diaphragmatic defect. And these are the ones that will require complex repairs. They would require counseling that is far more complex than, oh, we'll do a karyotype, exclude everything. No, there's a different flow to those, and therefore we will follow these up accordingly. So let's start with the first of these, the first of the two common ones, which is gastroschisis and omphalocele. And let's do gastroschisis first. Then gastroschisis, we realize that it's not so common as a general condition. It's about 4.4 cases per 10,000 live births. And bowel herniates through a paramedian anterior wall defect that is usually to the right of the cord insertion site. And the cause of this is not completely understood. Some say it's vascular, and some say it's abnormal regression of the right umbilical vein. But currently it's believed that basically when you have a folding with deficient mesenchyme of the embryo, that's when things go wrong. But that's not important for you and me. What is important is that yes, if you have a teenage mother, then they have a 7 times higher incidence of gastroschisis for reasons that we do not understand. Also, there is no sex predilection, and therefore we don't worry too much about that bit. Now, the diagnosis, of course, can be made as early as 12 weeks of gestation, and you'll notice from my images that I'm going to show you shortly that the vast majority of these are at 12 weeks. The umbilical cord insertion site is normal, and through a paramedian defect, you will find loops of bowel that are way outside the abdomen. And you can have protrusion of the stomach, which is rare, protrusion of the urinary bladder, which is also rare. But invariably, you'll find that you have the stomach, which is positioned abnormally, and the gastric fundus is pulled towards the defect. And this is a very useful thing when you're looking at an omphalocele. So sometimes you get a little bit of difficulty when you're looking at a gastroschisis. If you sometimes try to figure out what is going on, you will realize that the vast majority of times in a gastroschisis, the stomach is just not right. Then remember that if it has progressed to intestinal atresia, which happens because of the effect of amniotic fluid, then you can get dilatation of any segment, and that is important to look for. Remember that dilatation may be progressive, and ultimately you have a massive necrosis of bowel, and you actually have something which we call the vanishing gut, where a large segment of the bowel just disappears, and you saw it 4 weeks ago, and the patient comes back, you see much little less, and you think, oh, has it gone back? No, that's not true. It's probably undergone atresia, and that is associated with a problem, because then those fetuses don't do so badly in the neonatal period. Also remember that about 14-15% of these fetuses will have additional abnormalities. So even at 12 weeks, we will look at the entire system, which is CNS abnormalities and cardiac malformations, and I'll show you cases so that you will remember this. Very rarely, there's another condition where limb muscles, particularly lower limbs, may be replaced by fibrous and fatty tissue, and that's called amyoplasia. And therefore, if you're following up a case of gastroschisis where the parents have decided to carry on with the pregnancy, remember that you must look very carefully at the subjective thickness of the limbs and the movements of the limbs to see what is the prognosis post-delivery. And of course, this will then form part of counseling as well. Intrauterine fetal demise is very uncommon in gastroschisis and is usually related to other anomalies which are major and not because of the gastroschisis itself. Now, here is a classic example. We have a fetus here, about 7.5 centimeters in crown rump length, about 13 weeks or so, and an interruption of the anterior abdominal wall, and you realize that things are bulging out. The nuchal seems good, and as you do a survey of the fetus, you realize that yes, indeed, there is a portion of the fetus which is perfectly all right, which is the head, the neck, and the thorax. And as you go lower, you will find that yes, there is a bulge. You study these bulges a lot better, and you realize that if you get the plane correct, you will stop struggling like we're doing in this part, but actually follow the cord, and it inserts lateral to the protrusion. The view in this situation, almost always, irrespective of fetal position, is far better with the transvaginal evaluation. And then this relationship of the cord with the bulge can be much better seen. Remember that the bowel is spread out wide and is not contained within a membrane, and that's a differentiating feature from an omphalocele. Remember also that since you are doing a vaginal scan, you will get a better opportunity to look at the rest of the anatomy and look for associated malformations, even though they would occur only about 14 to 15% of the time. Another case here to show that you do have to make an effort even to see the lesion when you're doing a vaginal scan. So if you don't look at everything outside carefully, you might think that what you see here is actually just umbilical cord and not realize that some of these are bowel segments. So have your gain settings absolutely correct. Look at things in real life, in real time, and never actually try and make a diagnosis on still images or videos that you haven't done yourself. So if you have it worked out correctly, then you'll realize that yes, some portions of these are limbs in cross-section. Some portions of these don't look like umbilical cord. Umbilical cord should look like this, as you know. And that the rest of it is all bowel, and it might take a bit of an effort to look at. Because of this also, very often you will be able to get a better view because the fetus is moving off the cord insertion. But if you're not sure, just persist until you make sure whether this cord insertion is truly separate from the actual abdominal wall defect so that you can have a proper diagnosis of gastroschisis, and you can't be in a hurry to be doing this. Another example here, again, a abdomen which is small, a stomach which is pulled, and an anterior abdominal defect through which we find a bowel coming out. And then we say, all right, is it an omphalocele or is it not an omphalocele? Is it gastroschisis? And you realize that the cord insertion is quite to the side of the lesion, therefore it's gastroschisis. And then you're doing a survey, and here you find that the spinal cord gets splayed and the vertebral column stops abruptly, and that you have a large heterogeneous mass sitting at the back of the spine over here, and you know immediately that this has echogenic material within it, so it's either a minor meningocele or a lipomeningomyelocele, and therefore then has a completely different poor prognosis compared to an isolated gastroschisis, which has relatively decent prognosis. Now, here is another example. Yes, loss of contour. I wasn't sure on whether this was an omphalocele or a gastroschisis, so we watched carefully, and to the not so convincing, I still wasn't sure whether I was looking at an omphalocele. Stomach seemed to be in its okay place, so again, probably too early. And then when you switch on color, you realize no, the cord is very distinctly going in lateral to this mass, and therefore this has to be gastroschisis. And of course, you can do a reconstruction to confirm that whole process. the cord comes here, goes around the mass and around that area of bowel, and then enters the abdominal wall lateral to the mass. But here there is another problem. When we focus the heart, you realize that I don't see a crux at all. And when I switch on color to define anatomy, I realize that there's a big mess at the atrioventricular junction, and both the AV valves are just not right, and therefore there is an atrioventricular septal defect, and therefore then it's not the gastroschisis that will have the responsibility of the outcome, but the AVSD, which then becomes different. And then, of course, typically for a gastroschisis, we don't have an association of chromosomal and genetic abnormalities, and you won't have those investigated. But here, when you spot this, then this is likely to be syndromic or genetic, and therefore the entire thinking goes in a completely different direction. So what kind of workup would we do? Well, the first thing is that imaging is the first step. You confirm the relationship between the cord and the bowel. You try and make sure that there's no associated abnormalities. Here, this large median defect would give a different diagnosis. Here we realize that the defect extends all the way down into the perineum, a different diagnosis altogether. This is a cloacal exstrophy and probably a facial dysmorphism as well. But if you have excluded all this stuff, then the risk of chromosomal abnormalities is low, and an amniocentesis with a conventional karyotype or a microarray is not really recommended if you're sure. Therefore, you will not push for that. Although some departments have a general policy that any abnormality that the patient decides to carry on, you will do a microarray, then that's different. But by itself, you don't have a risk of chromosomal abnormalities. Serial follow-up is recommended to assess for edema of the wall or dilatation and atresia, and this is important. And usually, once you diagnose and confirm this at about 19-20 weeks, and the patient decides to carry on and the investigations have come out okay, you will then review at about 28 weeks and then every 4 weeks thereabouts to make sure what the status is. And some people suggest maybe I should see this at about 24 or 26 weeks, because in case there's been a progress to a dilatation because of an infarction or because of necrosis, then the patient still has the option of termination provided they take the permission of the court. So typically, if you look at the newer set of laws for termination, where the patient still has an option through a medical board and the district court, then maybe a 24, a 28, a 32, and a 36-week scan would be in order for this. Now, the other decision that the obstetrician would want to know is vaginal delivery or cesarean section. Laceration may occur in both a vaginal delivery as well as in a cesarean section, and therefore it's not easy to decide. Also to be considered is that there is a theoretical chance that a vaginal delivery might actually result in sepsis through the birth canal, and that could lead to a severe fulminating septicemia and peritonitis in the fetus and in the newborn, and therefore you need to be careful about that. If all that goes fine and the surgery goes all right, either as a one-step or a two-step procedure, then the survival is greater than 90%. Do remember that the survival rate is high, but there could be morbidity. So we're talking about a mortality rate of only 10%, but a morbidity rate which is much higher at about 40%, because sometimes you could get, of course, bowel atresia, infarction, you could get a constriction and again infarction. And because the bowel has been lying around in amniotic fluid too long, you might actually get a hypoperistalsis, and that hypoperistalsis is something that you need to be aware of. Sometimes it's transient, sometimes not so transient. You could also get a volvulus or a malrotation. And then sometimes the bowel is just too much to get back into the abdomen, and then you get something called an abdominal compartment syndrome, where the bowel just cannot be contained within, and that's a surgical complication. But the fact is that your job and mine is to make sure that there's no underlying abnormality in terms of structure. If there is, then that would require a amniocentesis and a microarray. But if there is no abnormality and this is isolated, then we can pretty much get away without an invasive procedure. Moving on to the next bit, omphalocele, which is a protrusion of contents through the anterior abdominal wall at the base of the umbilical cord to a variable extent and to a variable width. And typically This is what it would look like at about 14 weeks. This is a newborn. A little more common than gastroschisis, 2 to 3 cases per 10,000 live births. And basically what you have is a bunch of theories that say, look, maybe that the abdominal wall doesn't close, maybe that the bowel doesn't go back, but that's not important. The fact that you and me have to observe is that, look, something is, where it should not be, and therefore we have to do something about it. Now, omphalocele that contain more than 75% of the liver are referred to as giant omphalocele. But apart from the liver, the other contents of an omphalocele could be bowel, which is fairly common, liver, of course, and other viscera, but the peritoneum and parts of mesentery are fairly well always seen in this if you look hard enough for them. The defect is covered by a membrane, and this membrane consists of two portions, amnion on the outside and peritoneum on the inside, and it's devoid of skin. Skin stops at the base of the omphalocele, and this is one of the differentiating features from a simple umbilical hernia, which we will discuss after this section. Now, polyamnios is common, and ascites may occur, and there might be ascites within the omphalocele as well. And it's very, very important that we always confirm the course of the umbilical cord with the help of colored Doppler or power Doppler. And of course, at 11 to 14 weeks, that we always do a vaginal scan. Now, there's a whole lot of genetics involved with omphaloceles, and therefore it's wiser to actually send them off for a genetic evaluation because you have to think in terms of omphaloceles, and pardon the spelling mistake here, omphaloceles with a thick NT have a high incidence of cardiac defects, and therefore you have to look at the heart very carefully. And then also we know that overall there is a very high incidence of chromosomal and non-chromosomal abnormalities. So we must look at the chromosomal abnormalities carefully. Commonly it's trisomy 18, but also trisomy 13 and 21, tetrasomy 12p, and a large number of duplications and deletions. So for a quick diagnosis, we run a QFPCR or a FISH on this, and always wait for a microarray report before you give any clearance, because there's a large number of other genetic conditions. 10% of all omphaloceles are syndromic, and the two most common ones are the overgrowth Beckwith-Wiedemann and, of course, Miller-Dieker. And then again, the investigation will be quite different in terms of genetics. About 1/5 are associated with major malformations of other regions, such as the heart, the central nervous system, and urogenital malformations. And you have to be careful that you're looking at a simple omphalocele or whether you're looking at a complicated complex omphalocele. Also, it's a component of a lot of other more complex anterior wall defects, such as cloacal atrophies and the pathology of Cantrell, and we will discuss these. If you have a chromosomally normal fetus, then most of these infants will reach normal weight and height by the end of 2 years, and they'll do pretty well. But in case you have additional anomalies, then those anomalies will actually talk more about the prognosis than the presence of an omphalocele. Do remember that there is a very small number of these fetuses that do go on to develop respiratory symptoms in childhood, and those that then become permanent. Therefore, as part of the counseling, you have to let them know that, look, we cannot predict whether they will have respiratory symptoms. We don't completely understand the logic of those as yet, but it should form part of counseling so that people don't think that it's all rosy and that they don't need a follow-up. These are important things for people, for the parents, because they have to decide whether they want to continue a pregnancy which is genetically normal or not. Now, classical example here, a fetus at about 12 weeks and a day, a bulge over here. You can't tell at the moment whether this bulge is truly an omphalocele. You must demonstrate the cord, and not the blood flow within, because that would be hepatic blood flow, but the fact that the cord inserts at the apex here. And always look for this in real time. So here is another fetus, again about 13 weeks, and you see this narrow base, bulge, cord insertion confirmed like so, with cord inserting at the apex. And you look at it from different angles. Yes, there's the cord inserting at the apex, and this to help the patient understand what is truly going on and for your colleagues in pediatric surgery. And now we're looking at another situation where it's not just an omphalocele, it's about a 3.5 centimeter omphalocele containing most of the liver. So technically it becomes a giant omphalocele. But very close by there are cystic spaces, and I want to figure out whether this is loculated ascites or whether this is an umbilical cord cyst. I look carefully and I realize that it's quite separate as a cyst. That then changes the general prognosis, and I will accordingly not like to give a rosy picture that, look, we'll do genetics, if that's okay, we're okay. No, there's umbilical cord cysts, and we know that second trimestic cord cysts are more sinister than first trimestic cord cysts, and therefore then I would wait for my entire microarray report to come back and store up some DNA just in case someone comes up with something different as time goes. The cord has to be traced all the way through these cord cysts, as you can see, and then make sure exactly where is the point of insertion on top, and then trace it all the way in, and then of course a complete survey to exclude absolutely other associated abnormalities. Remember that syndromes of 13 and 18, like I said, are fairly common, so is 21. And so when I saw this omphalocele, and this was a long time ago when we were most excited, we used to do 3D on just about everything, and very often we used to pick up good things like this, the thumb absolutely on the inside, then the middle finger and the ring finger over the thumb, and then the little finger and the index finger on the outside. And we know already from this kind of a clenched fist that this would obviously turn out to be a trisomy 18, but we would still wait for the QFPCR report to confirm that before we go ahead with a termination of the pregnancy and a complete counseling. Now, we've moved beyond omphaloceles and try and define what is different, and that is an umbilical hernia. So this is the third condition. And the difference here is this, that an omphalocele, as I showed you before, is something that is covered with amnion and peritoneum. There is no skin. An umbilical hernia has a skin covering, and it contains only bowel and a small quantity of bowel at the base, and sometimes this can be larger. And then we try and make sure how much a bowel enters and that there is nothing else apart from bowel. It can be a little tricky in trying to say, is this definitely umbilical hernia or will this grow into an omphalocele? But if you find this little rim of lucency around it and a relatively thin covering, then you know that yes, this is omphalocele and not just a simple umbilical hernia. It's very common, and it is seen fairly frequently. Some people don't even regard it as a defect. Some of them, in fact, just heal on their own. A few of them would require surgery. There's a facial defect at the umbilicus through which these protrude, and there's always a skin covering, and the cord insertion site is always normal, which means that the cord will still be in the right place, and along the cord you will find this coming along. Now this is very important to understand and in fact follow up, because as these go on, some of these can be tricky, and the case that I always find very interesting is by my colleague Bimal Sani, and he told me about this one case, and we'll just go back to his slide for a minute, and that was that this was a doctor's wife who by accident happened to deliver in the ambulance. Someone clamped the cord, but it was too close to the umbilical end, and that resulted in a necrosis and a perforation and a septicemia, but luckily that baby pulled through. So if we have a herniation, do follow it up at 36 weeks during a term scan to make sure that how much more bowel has gone into it. It could sometimes go for a long length of distance, although it would still be called an umbilical hernia because it's covered by skin. So umbilical hernia doesn't mean that it will always be small. It could be larger. So, and then of course, if it's going to be one of those dramatic ambulance deliveries, we would have messed up things completely. Moving on to our next condition, which is bladder exstrophy. Rare, 1 in 30,000 males, but important to recognize because the prognosis is quite different. Basically, there is a failure of the lower abdominal wall and the anterior bladder wall to close in the normal way, and the cord insists in the correct place, although sometimes it might be a little lower. The anterior wall defect is inferior to the cord insertion site, which means that when we look at the anterior abdominal wall, we have to look at the portion of the wall above the umbilicus in a view of the fetus when we look at it in a sagittal section. And then we look at the cord and we look inferior to the fetus, and then we try and see what is going on in that, and that contour should also be smooth. So the way we look at the anterior abdominal wall has to change. It's not just that the wall is there. No. The wall has a cord insertion. The wall has an upper abdominal component, a lower abdominal component, behind which is the urinary bladder, and below which is the genitalia. And the usual proportion between the bit above the cord and below the cord is almost equal. And the cord insertion should always be at that point. And in a bladder exstrophy, it will often be lower. Now, the main finding in this is that you will have very clean looking kidneys, no hydronephrosis, you don't see a bladder, and you find normal amniotic fluid, and the bladder just doesn't fill. So in that situation, you start thinking of a bladder exstrophy, and you look at the anterior abdominal wall more carefully, and you realize that, yes, there is an irregularity that I need to look at. Basically, the bladder halves are exposed and everted, and therefore the bladder just empties into the amniotic fluid. The fact that it's sitting and lying in amniotic fluid might cause irregular thickening of the posterior bladder wall, and that might be seen as an irregular contour of the anterior abdominal wall, because the front of the abdomen is actually in fact formed by the bladder wall. Now, genital abnormalities do occur in association with bladder exstrophy, and therefore these need to be looked for. And as usual, we have that dilemma in our minds. Should I do a sex determination or should I not? Technically speaking, and in the strict laws of the PCP&DT Act, we do understand that you can and should do a sex determination because it affects the prognosis. But we do understand that we live in an ambience which is extremely unpleasant actually, and therefore we may have authorities that do not understand the complexity of this, and therefore you have to realize what the local rules are like, and you might mention it in some vague form in your report, but the best thing is that you have a good relationship with the authorities to explain to them, after all they come from diverse backgrounds, that look, this is a situation where the PCP&DT Act justifies this. But if you don't have that relationship, then it's better not to get into trouble. And then you just mentioned bladder exstrophy with genital ambiguity and so on. Now, the kind of problem that we do find in males is epispadias, where a short or split penis is seen, and male-descended testes are common. And in the female, you find a bifid clitoris and uterine and vaginal anomalies. And in fact, if you start seeing a fluid-filled uterine and vaginal anomaly, then you move on from a diagnosis of bladder exstrophy to a cloacal exstrophy. So bladder exstrophy usually will not cause a fluid dilatation of the uterus or the vagina. That's what it looks like, that you have a cord which is relatively low on the anterior abdominal wall, a bladder where the front wall is truly missing, and you have a bulging of the posterior wall, which is the pink portion you see here. Then you see here that there is a wide split in the female genitalia, and here a wide split in the penis with an epispadias, and then testicular abnormalities would show up like I already mentioned for you. Now, it's essential to differentiate bladder exstrophy from cloacal exstrophy because the prognosis and management of a cloacal exstrophy is far more complicated, and it's nice to have a diagnosis because the bladder exstrophy does not have such a severe bad prognosis, and some of our patients with precious pregnancies, IVF, and so on would actually be quite different in looking at what to be expecting. Now, whether these two, in fact, whether a bladder exstrophy and a cloacal exstrophy are two different entities, again, is some sort of a matter of doubt. But we do understand that they have the same underlying pathogenesis, and therefore there would be variable severities between the two. But essentially, it's important to realize that yes, this is the way the situation is, that unlike in cloacal exstrophy, the bowel loops never extrude in a bladder exstrophy. If you find bowel exstrophy, it's a cloacal exstrophy. and the rectum is normally formed in bladder exstrophy, whereas it is not normally formed and the anus is absent in a cloacal exstrophy. Now, additionally, look at these findings, that you find that you keep on picking up a nice clean midline artery portion, but the bladder actually doesn't fill. The bladder wall doesn't seem to be right. The umbilical artery relationship doesn't seem to be all right. There is an ambiguity of the genitalia that you're picking up here. One of the biggest problems is that you never get to see the abdominal wall sometimes as nicely as you would like to. So here we have a cord that comes along, a low insertion, and then you have a bladder that doesn't fill, and then very prominent genitalia here that look completely ambiguous. I can't tell at the moment whether it's a small penis and a non-descended testes, or whether it's actually a labial hypertrophy and a large megaclitoris. So that is something that you have to be careful with. And usually a lot of these fetuses do not come into a sagittal position with the anterior abdominal wall on top, and therefore you have to be very, very patient, see them again and again. Don't depend on just axial views to try and figure out what is going on in the anterior abdominal wall. Wait patiently, and only when you wait patiently and you get a view from the pelvis upwards and you get a view from the sideways showing the anterior abdominal wall from left to right, only then should you make a full diagnosis or realize that you made a full diagnosis and not missed out on the possibility of a cloacal exstrophy. 3D, and here are two pictures from the internet. This kind of prominence of the wall is something where we do find that is something that happens in the third trimester. You rarely pick it up in second trimester. And this kind of a reconstruction, as you see here, is something where you realize that, okay, here I do see ambiguous genitalia, I see it, but it's very, very rare to actually pick up images like this. And most of the time you would pick up something like this with the feet partially abducted, ambiguous genitalia, and a bulge right above that. And then, of course, you go back to 2D, you go back to color, and you try and make a diagnosis. If you see it with 3D, it's very, very convincing. There's no doubt, as you saw from these two cases, and it yields a lot of information, but it's not the easiest kind of 3D to do. These, like I said, are from the internet. This, of course, is my own case. Now, one new discovery that helps us sometimes to differentiate between an omphalocele and a bladder exstrophy is the angle that the umbilical arteries make with the aorta. Normally, this is an acute angle, as you see in this 14-week fetus, or 12-week fetus actually, and this angle here is an acute angle, and this has been worked on by an Indian worker. Her name is Kavita Aneja, and I'm very proud that she described this first in our Indian Journal of Radiology and Imaging, and she said that, look, if you look at the cord vessels carefully, you will find that this angle gets widened in a bladder exstrophy, and instead of being an acute angle, it actually opens up and might even get to be square-shaped. It's called the K angle, which is after her first name, and this is a great finding for helping us to differentiate between an omphalocele, where you will find an acute angle, an acute K angle, or a bladder exstrophy, which includes the more complicated omphalocele like Oes Complex, where you will be able to figure out a much larger angle. Now, remember that often you have a bladder exstrophy and an omphalocele, and then this starts moving into more complicated abdominal wall abnormality, which in its full form is called the OEIS complex. The O stands for the omphalocele, the E for exstrophy of the bladder, the I for imperforate anus, and the S for spinal abnormalities. Remember that OEIS is an easy way to remember this condition, and you will find all four, but sometimes you might not find all four, and you might find just an OEI, which is omphalocele, exstrophy, bladder, and imperforate anus, and sometimes you might not find the omphalocele, and you find only an EIS complex, which is exstrophy, bladder, imperforate anus, and the spinal defect. So these are the combinations that you can have, and for many of these, to see how much omphalocele, how much exstrophy bladder, it's truly, truly very comfortable to be able to work out the K angle. And I, like I said, feel very proud about the discovery of this K angle. What do we do with bladder exstrophies? Not often associated with abnormalities in terms of genetics. Initial repair is done in the postnatal period, and it's done either as a single procedure where you have a primary repair of the exstrophy and a repair of the epispadias, or as a two-stage procedure. But do remember that in counseling, you have to tell your patient that, look, very often, this is not something that's going to be happening continuously, and that you have to be particularly careful in realizing that, look, there might be a stormy postnatal course. So that has to be described. You also have to mention that ambiguity of genitalia is looked upon quite differently in a culture of ours compared to the West, that the cosmetic function may not be perfect, that there might be incontinence. So all of this then forms part of the bladder exstrophy imaging and counseling, and the clues for incontinence and the clues for the fact that there's going to be a 1 or a 2-stage procedure do not come from imaging. So we cannot overly reassure our patient that everything will be fine, and in your precious pregnancy and you're 41 and this is IVF, you should go ahead. No, let them make their own decision that, look, there are certain ambiguities, not only of the genitalia, but in terms of what might happen in the postnatal period and what might happen with the surgeon. And therefore, you have to be careful in the decision that you make. Cloacal exstrophy is different. Rare, there is a low anterior wall defect, the absence of a visible bladder, but you have an exstrophy of all structures that form the cloaca, which is the rectum, the urinary bladder, and the lower genitourinary tract, which means the entire urinary passage. There's a lot of theory that goes on about this, but that does not concern you and me. What we need to realize is that typically what we will end up observing is the fact that there is a cord insertion which is low, and that the abdominal wall extends far behind that there is bowel right in the middle, which is actually an omphalocele, which forms the more cranial part of the extensive defect, that this bowel herniates out through the two halves of the urinary bladder and creates this elephant trunk appearance, that the anal atresia will mean that the anal dimple is absent, that you will find spine abnormalities, and this little bit here are the wall of the urinary bladder on either side, and therefore then you get this overall appearance of the elephant. So there is the cord, the umbilical cord, there is the bowel, there is the lateral walls or portion bulging of the bladder, and then of course further bulging of the entire system, and no anal dimple and spinal defects when you specifically look for them. The entire rectal area lies open, the vaginal area lies open, everything lies open, and it has a very bad prognosis. 60% of them have additional urinary abnormalities, and you have to be careful about those. And this was one of the cases we came across. You realize here, very abnormal bulge of the abdomen. Not the ideal image, there's a lot of overlap, but sometimes this can happen. But the clue lay here that yes, along with this, very poorly defined anterior abdominal wall, and then membrane here, bulging here, bilateral hydronephrosis of mal-ascended kidneys and so on, normal at the moment, normal amniotic fluid or just a little reduced amniotic fluid, and therefore you start thinking beyond. Then you wait and wait and wait till you're able to define the anatomy. Remember that in good ultrasound, there are no shortcuts. I know we repeat this very often as teachers, but the fact remains that there are no shortcuts. There are those cases that will take you the better part of your day, and this is the way that this is actually going to be working. Now, there is this role that people say of MRI, which might help. Yes, MRI reconstruction might be useful. This is an image from the internet. But look at the rest of this case. Difficult to define anatomy in the lower anterior abdominal wall. The clue lies in the fact that these genitalia look like we're not able to say whether they're widely separated labia or whether it isn't widely separated labia and it might be just an abnormal scrotum. We try from every possible angle. We realize in 3D reconstruction that we're not able to see the anterior portion, but we see the inferior portion, that there is the natal cleft coming all the way here, but beyond that, nothing where I would be able to even anatomically look for an anal dimple, that the perineal anatomy is completely distorted. So not the easiest thing to do, but something that you have to keep in mind, something that you persist with. It's not something you're going to see again and again, but if you keep this as a differential diagnosis, you will realize that things actually work out well in terms of forming a full diagnosis. Now here, in case the patient decides to carry on, it requires a multidisciplinary team. You will have to put that together. Counseling becomes extremely important, and sex assignment is something that is extremely important, and therefore very often you might need to do an invasive procedure for doing a postnatal sex assignment. And then the entire counseling can go on from there. And then, of course, there would be a declaration of sex, and that's well within the realm of the PCP&DT law. But like I said, you have to consider your own condition in terms of the local environment and then decide how to handle it. Coming to the last few conditions, the Bodystock anomaly is also sometimes called the limb-body wall complex. Some like to differentiate it. It's lethal. There is no umbilical cord. Very, 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 very rare. Both in, and you can have live births in which it is rare. You can have stillbirths again, which it is rare. And the visceral organs are attached to the placenta. There's almost no umbilical cord. Various hypotheses on why this happens, not important for you and me. But the important thing to realize is that from whichever angle you look at it, the viscera is lying outside and stuck. The fetus can hardly move, and you don't see a sizable umbilical cord. Now, the other thing is that the cord insertion can truly not be identified, and you don't see free-floating cord. Whatever cord you see, free-floating loops of cord are just not seen anywhere. All that you see is some vascular signals where the fetus attaches to the placenta, and there's often a severe kyphoscoliosis. You can have a lot of limb anomalies, which you will actually look for more out of interest than anything else, because anyway the outcome is hopeless. And MR, although has been described very, very beautifully, so to say, but that's not the way to look at MR. We want MR that yields information. You don't really need an MR in this situation for information. The rest of the fetus can be surprisingly very, very decent looking, but disruption over here, no cord except a vascular connection to part of the placenta. And then when you trace it in 2D with color, not so terrific, but the moment you do a 3D reconstruction with flow, and you see this image here, this is the heart, that's the carotid circulation, and here you find just tortuous vessels which adhere the whole fetus to the placenta, and this then becomes a very convincing evidence of a limb-body wall of a Bodystock anomaly. And you notice that the lower part of the fetus is not really properly formed. I was going to show you that a Bodystock anomaly is something that you don't always have to wait for, even for the 11 to 14 weeks window. And if you were to tune yourself to not just to any ordinary crown rump length at the usual 8 to 10 weeks dating scan, and you find that the embryo doesn't look so good, you will then straight away start looking to see what the cord looks like. And here you realize that there is almost no umbilical cord. You'll follow this up by 11 to 12 weeks to get greater confidence, and you will have a Bodystock anomaly diagnosis well in time for making a full diagnosis and reaching the point of saying confidently that yes, at 12 weeks we've identified this. A Bodystock anomaly is not generally associated with chromosomal abnormalities, and therefore it's not something that needs investigation or recurrence or any such thing. Yes, some people say associated with diabetes, but that's not consistent, and so that's the only thing that needs investigation. But basically the patient can opt for a termination of pregnancy because this is uniformly lethal. We come to the pentalogic cantrell, which is an upper abdominal wall abnormality. Again, very, very rare. The complete pentalogy is something that we don't pick up on ultrasound because it consists of congenital heart disease, defects in the lower sternum, anterior diaphragm, diaphragmatic pericardium, and supraumbilical abdominal wall defect. The presence of a pericardial diffusion indicates that there is communication between the pericardium, the pericardial sac, so to say, and the peritoneum. And the constellation of defects is because of some sort of migration disorder. Like I said, embryology is not my forte. I've never really found it useful. I find the observation of an image far more useful. An association with trisomy 13, 18, and Turner's, and therefore well worth investigating from a genetic point of view before a termination. When all 5 defects are present, that's called class 1, then invariably there's a poor prognosis. But there are milder forms. In class 2, you have intracardiac and ventral wall abnormalities. Class 3 with the sternal defect and mild expression of the rest. So you might have some survivors with an ectopia cordis, but in general, it's a fairly hopeless situation that is very difficult to repair. And this is what it looks like. You have a heart that's really low down, coming into almost outside the thorax and abdomen, a large omphalocele, and these two are the main markers that you do pick up. Therefore, whenever you see an abnormality of like an omphalocele, always look for the cardiac location and see whether it's up in the chest or very low in the chest and almost in the abdomen. Now, the other thing we need to do is to make sure that you try and make sure that all the cystic spaces should not be labeled as stomach. You would like to label these as other things as well. For instance, you would like to say, yes, maybe this is actually loculated fluid, and therefore then there would be abnormal communications between the pericardial sac and the actual abdominal cavity. Now, an early diagnosis of conditions like this is being possible, and this is a case that has inspired me for almost a year now since I discovered it last, where we find a fetus that is fairly young. You can see that the rhombencephalon is still very prominent, that the heart is lying almost entirely out of the thorax, and then there is echogenicity here. And then what do we see? We see most of the heart outside. We see a cord insertion here. We see a protrusion of abdominal contents above the cord insertion, and we see a protrusion of abdominal contents below the cord insertion. So this is a gross defect. But because we're familiar with anatomy now as early as 9 to 10 weeks, it is possible that the morphology might actually shift from 14 to 11 to 10 weeks. And that seems to be a possibility for the future, that very, very gross abnormalities would be picked up even earlier. And these, of course, then would require genetic evaluation in some of them, not required in some of them, and therefore we don't have to prolong a pregnancy for those reasons. Now, amnioschisis, the last thing, which is actually a abdominal wall defect arising not because there has been an abnormality within the fetus while developing between 6 and 8 weeks, but because there's been a amniotic disruption, either vascular or physical, and the sticky parts of the amnion then peel away the anterior abdominal wall as they would peel away any other part of the fetus, and then you would end up with appearances like this, which are completely bizarre. The bowel looks bizarre, the liver looks bizarre, fluid collections look bizarre, and we're not able to identify a proper anterior abdominal wall. Then you know you're truly looking at an anterior abdominal wall defect, which is an amnioschisis. You may or may not find the amniotic bands anymore. At this stage, they might have all atrophied after causing the damage, and therefore the diagnosis will still remain amnioschisis. It might be isolated, which means only anterior abdominal wall, or it might be part of a more diffuse defect. Like I said, prune belly I like to include here, which some people believe is not truly a defect, but a megacystis that bursts out. Some believe no, it's actually a defect of the anterior abdominal wall. But remember, this is always a differential diagnosis, and therefore when we see a bladder exstrophy, there is always a prune belly option there. We know that with bladder exstrophy also the genitalia are partially there, and there might be a urethral defect, but in prune belly you might not have abnormal genitalia, and therefore sometimes they might be open to repair, although most of the time these become non-functional urinary bladders, and the kidneys also become non-functional by term. Therefore, it's not something that has a good prognosis. So in general, what should be our exercise? The first step is that in every ultrasound scan, look at cord insertion onto the anterior abdominal wall with color Doppler and confirm that. Confirm the urinary bladder with umbilical artery so that you don't incorrectly label an abnormal cloaca, for instance, or a urachal cyst, for instance, as a urinary bladder. Complete your anatomical survey carefully, particularly if you don't find that the wall is right, the anterior abdominal wall above and below the cord insertion. Make sure that you remember that associated abnormalities can alter the prognosis of anterior abdominal wall defects. And for that, you might want to go ahead with a genetic sonogram, a 3D color Doppler, and maybe MRI. And then you go on to QFPCR and microarray from the invasive testing. Remember that when you're doing any of these, you're invariably storing up DNA as well. So that if anything comes up on an autopsy or on a clinical observation after the fetus is born, then the DNA can be appropriately analyzed at a more expert level in terms of a whole exome sequencing or even a Sanger sequencing in case one unusual syndrome can come up. But let me close with my first slide, which says step number 1, look at the cord, normal or abnormal. If the defect is to the right of the cord insertion, gastroschisis. Defect below cord insertion, bladder exstrophy. Abnormal insertion, and absent bladder, cloacal exstrophy. Cord insertion on the membrane surrounding the defect at its apex, that's the omphalocele. A defect above the cord insertion, that's pentalogy of Cantrell, and a bizarre arrangement of the abdominal viscera or a missing umbilical cord would then point towards an abdominoschisis or a Bodystock anomaly. Thank you so much for your attention, and my apologies for the interruption. We've received a large number of questions, and I'll take these through. And here is whether the OC-AC ratio is helpful to prognosticate the outcome of an omphalocele. Now, the OC ratio refers to the omphalocele circumference ratio and generally refers to the amount of size that you have. The size on omphalocele actually depends on the quantity of liver. And giant omphaloceles, which contain more than 75% of the liver, actually would therefore have a poorer prognosis, because when you put that liver back, there can be kinking of the liver vasculature. So although you could quantify that by using an OC-AC ratio, it's not something that's routinely used, because a subjective evaluation of the liver and the total size is equally useful in giving you this. So it's not routinely done. So should microarray be done or FISH after anterior abdominal wall defect? If you see a gastroschisis which is isolated and is truly isolated, you don't need to do it. If you see a Bodystock anomaly, that's lethal and you don't need to do it. For all the others, you do need one. So you do either a QFPCR and FISH for a quick diagnosis, and you would do a microarray for microdeletions, duplications, and the tetrasomies. Third question, is there any relation of genetic association with size of omphalocele? More the size, more the association? No. You could have a very small omphalocele and you could still have a syndromic association or a genetic association. Sir, can you please explain about umbilical cord varix? If present, how often do we have to follow up? And umbilical cord varix is a dilatation of the intra-abdominal course of the umbilical cord and is not part of an anterior abdominal wall defect. And we will, of course, talk about this in various other webinars as we go along. We have one on flow and we have one on abdominal vasculature, and those will come to you within a month or so. How can we differentiate a cord from normal intestine before 12 weeks? Most of the time, if you have good resolution and you have a transvaginal view, you will be able to see the difference between vascularity, which is color, and echogenicity, which is bowel. And if you have any doubt, repeat it at 14 weeks. Okay, we have a question which says, I'm not sure if it is 100% rule for cord insertion at the apex of the encapsulating membrane, as atypical forms with a lateral insertion have been described. Technically speaking, you're right. When we see these at 11 to 14 weeks, they're always at the apex. Beyond that, you could actually find a differential shrinkage of the amnion or the peritoneum, and therefore the cord appears relatively to one side. Also, very large omphaloceles tend to fall left to right, and when they fall left to right, then we get stuck with trying to see what is the true center of a round structure, and therefore it appears more lateral. the whole thing gets pretty much sorted out the moment you switch on color, of course, and the whole thing will get sorted out completely if you were to switch on color plus 3D at 40. So a lot of the ones where I used to think that it looks relatively more lateral, it's not absolutely at the apex, was truly because in 2D sections, I wasn't looking at what was the true apex of the omphalocele. So it's more a question of how something looks when we're looking at it from a different perspective, from above below, from below downwards like this, from above downwards, and so on. But it's not that there is a true difference, it's always more or less at the apex. Then we have is echogenic bowel wall on antenatal scan around 13 to 17 weeks important. Well, of course, it is extremely important, and I promise you, we've had webinars before, but we will put all our webinars onto YouTube or the Society of Fetal Medicine YouTube channel when it does come up, and you will have all the answers to echogenic bowel. I will skip this question because we're sticking at the moment to anterior abdominal wall. How do we diagnose umbilical hernia? We've been through this, and I noticed this came through before. How do you differentiate between cystic mass, renal cystic, or polycystic kidneys or renal hydronephrosis in the fetus? We will refer you to a previous webinar we've done with the Society of Fetal Medicine on congenital abnormalities of the kidneys and urinary tract. This is a whole talk by itself, and I won't take it because it doesn't really have a direct bearing on the defects of the anterior abdominal wall. Physiological herniation cut off at 7 millimeters or 10 millimeters. We tried both over the years, and I've been around 39 years, 40 years in ultrasound. So when we used to use a 7 millimeter, we were overdiagnosing some of our physiological bowel herniations, and therefore it's a question of the predictability. So we started using a higher cutoff. That you don't want to go either way, overdiagnose or underdiagnose. And therefore we keep 10, and whenever there's a doubt, like I said, never go by, is it 9 and therefore it now becomes this, and is it 11, therefore now it's pathological? No, just follow it up at 14 weeks if you have a doubt. Then there is how to differentiate between limb-body wall complex and amniotic band syndrome. In an amniotic band syndrome, you find that the disruption is far more extensive, and to a certain extent you might even find this in a larger fetus which tends to grow otherwise all right. In a limb-body wall complex, the entire viscera comes and gets stuck to the placenta, and sometimes you can't always tell, particularly as these fetuses become oligoamniotic. You may not be able to tell the difference between one and the other. But in terms of vascularity, somewhere in an abdominal schisis, you might actually find one odd segment of the cord floating here and there, although it might have a bizarre relationship with the abdomen. In a limb-body wall complex or the Bodystock anomaly, you will find that there's just that stump of vascularity that's sitting over there. What does an exomphalus look like on ultrasound? We've answered that question. What should be the frequency probe for looking into the anterior abdominal wall of the fetus? It depends on several things, like for the frequency of the transducer otherwise. So we have a choice between a standard 1 to 6 megahertz transabdominal transducer, which is good because it has depth. We have the single firing C2-9 transducers, which are fabulous because they have an inbuilt single crystal technology and they give us great images. We started using those. In between, if the anterior abdominal wall was truly anterior with the fetus in that position, we were using an 11 megahertz linear transducer. Just depends on what's available. We just use the best transducer that you actually have. The higher the wavelength, the higher the frequency, the better the resolution. Now, one of my relatives has small omphalocele at 12 weeks, and by 16 weeks it went into the abdomen, and now she has a healthy baby. Yes, so obviously this was an umbilical cord hernia. It was physiological, and that's why I keep saying if you have any doubt, do it at 14 weeks and look very, very carefully for associated abnormalities, and then never give a hopeless prognosis. Remember that there is always this doubt on what to do. By the time I do invasive procedures of a Korean villus sampling at 12 weeks, I may not always get my answer by 14 or 15 weeks because my microarray comes in later. So very often, and to overcome the effect of mosaicism, I do an invasive procedure at 16 weeks, by which case I get a better look at anatomy anyway. Typically, when I find an omphalocele, although many workers all over the world would say, no, do a CVS straight away at the same sitting, I give my patients an option because I know that by the time we end up terminating for an abnormality, it's going to be 16 weeks. It's going to be 16 weeks, and why not wait till about 17 weeks or 18 weeks for your results? Microarray is also coming out quickly for us with amniotic fluid now, and therefore we don't have to be too worried about it. But like I said, be careful of the diagnosis because you could still label normal for abnormal. And like you said here, 12 weeks and 16 weeks became quite interchangeable. Next list of questions, we really have a long list. Criteria for prognosis, we've discussed already. Anomalies of anterior abdominal wall, we've just spoken about those, my friend. Omphallo diagnosis of what period of gestation? Latest by 14 weeks, but most of them by 12 weeks. Then there is omphalocele minor is genetically related. It still might be, yes, and therefore, irrespective of size, we would do genetic evaluation. Common fetal abdominal congenital abnormalities. I don't know where this question came from, but I'm sure we'll have other webinars which are more taken. Tell me the main article where the blue boxes was taken from. The same one in radiographics, my dear. So radiographics about 5 years ago. It's a free download on the internet. It's an RSNA publication. It's from there. Difference between cord hernia and omphalocele we've already discussed. And then we move on to how to trace the ductus venosus. Well, we have a separate lecture on the ductus venosus. It's not related to my anterior abdominal wall defects. Then management protocols we've already discussed. And then, of course, there's a question on, well, we've finished all of those already. These are repeat questions. And then, can you suggest clear conditions when to suggest a 100% abortion option in these defects? I like this question. And I like this question because it gives life in a broader perspective. You and me should never say termination as the only option. The final decision is that of the patient. There might be patients who will carry on with a lethal abnormality, and we truly have to be careful about that as well. So basically in these situations, what would I do? I would tell myself, look, I want to be very, very sensible about all of this. I can show you that, look, this is not going to do well, but if you want to carry on till full time, they can do it. And they actually work. In that situation, if it actually works, then why should I interfere with their own thinking? So I always give the patient the option, look, we're not likely to have a healthy child, take your choices. We need to do genetic investigation, take your choices. Do nothing, take your choice. Terminate, take your choice. Lethal abnormality, baby will not survive, but if you want to carry to term, you can do so. You may not carry on to term because of a polyhydramnios that can be associated with some of these conditions, and you might have preterm rupture, etc. The prognosis may not be good because of prematurity from polyamnios. Take your choices. So there is no such thing as saying 100% abort option in these fetuses. There's no doubt that when I see a Bodystock anomaly, then we say, okay, this is absolutely lethal. Ontology also, some of them survive for a short while, with and without surgery. And therefore, again, you start wondering whether you give them the option. Tell them, look, baby with abnormalities, baby who has to struggle in the nursery. You want to go through it? We will go with you. We are with you. We will support you. But the prognosis is hopeless. This is the way that you have to carry on the conversation. What's the next question is, what is the best position to take the K angle? Is that a sagittal view? When I look for the course of the umbilical arteries at the level of the cord insertion, I do it in an axial view. When I look at the K angle, I always do it in a sagittal view, and that's the way to do it. Okay, I'll read out this question so that we're reading at the same time. Just to add something to this, whenever such a situation of gender determination arises, in the case of a bladder exstrophy, writing an email to district PNDT mail immediately or at the end of the day and directly conveying it to the provider concerned telephonically works out. Sure, if it does, wonderfully. Patient cannot be told orally about the problem. Yes, if you don't wish to tell the patient, but the point is that you can always mention ambiguity and tell them that it's not there. And it talks about being in good communication with the PNDT. That's always a good idea. Every now and then I walk into the PCPNDT office myself and submit my monthly report just to remain in touch. Or I send one of my senior staff so that we have a one-to-one relationship. And that's all about human relationships. We don't want to always be antagonistic to them. They're doing their job. We have to do that job. I mean, female feticide is alive in India. Someone has to do it. We know it's lost its original purpose. The vast majority of situations is where it's the bureaucracy versus the medical profession in terms of power. But let's face it, without the law, we'd be much worse off. So I have mixed feelings on this, but it's always nice to have a good relationship with everybody in the world. How to recognize anal atresia, we already have a good webinar on that, not part of an abdominal wall defect. And then there is this where to measure the size of hernia at 12 weeks gestation at the level, not where it is necessarily the widest, but I like to measure this at the level of the abdominal wall and the cord origin at the level of the abdominal wall, or the cord insertion as some people like to call it. Can you show different omphalocele and umbilical hernia? We've already done that. Then could you show the first line of cloacal astrophysics? I don't remember that slide. My apologies. The flow chart to deal with anterior wall defect, it's right here, Dr. Soumya. This is the flow chart for you. I've specially kept it for you. We truly have a large number of questions. And Bodystock syndrome, we've answered that question. A cutoff is at 12 weeks or 14 weeks. When in doubt, it's 14 weeks. When not in doubt, it's 12 weeks. Then, of course, as gynecologist point of view, which anterior wall conditions are legally permitted for termination? You can actually terminate any pregnancy. You don't necessarily need an anterior wall defect. All of them can be terminated up to 20 weeks, 12 weeks with one signature, 20 weeks with two signatures, and till the time of viability with permission. And if it's a serious disability, then with permission of the district court and the appointed board from the Ministry of Health and Female and Family Welfare that came out in September. That's been notified. The new MTP Act has not yet been notified. It's been passed by the Lok Sabha, will be passed by the Rajya Sabha, signed by the President over a period of time, and we will have the answers. Then there is by which gestational age is it possible to differentiate between omphalocele and gastroschisis? I always try to do this at the 12-week window. Then, so is this possible on a Premier machine, or do we need a higher model? In general, it depends on the actual status of the BMI of the mother. And the more obese the patient, you will need a higher end model because the transducers are smarter. The lesser the gestational age, you will need a higher end. In general, when you're doing fetal work, it doesn't seem fair to do it on a very low end because our patient BMIs are high. And therefore, I always end up doing my work either on a medium end or a high end machine. Then prognosis pentalogy control. Some people have carried on. It's usually hopeless, very difficult to repair. A true all-component pentalogy control is a lethal abnormality, and therefore we sort of give them the option of termination as one of the first possibilities. But you can tell them if you wanted to go through all the time, you can go right ahead. Then, of course, does bowel herniate in cloacal exstrophy and not so in bladder exstrophy? That is true. You can have an omphalocele and you can have a bladder exstrophy, but usually when you have a cloacal exstrophy, you have bowel that is herniating in front of the urinary bladder, and the bladder is part of the cloacal exstrophy actually. Then What is the difference between limb-body wall complex and abdominal schisis? Abdominal schisis is an acquired abnormality because of amniotic bands, and a limb-body wall complex is essentially a mesenchymal development abnormality where the cord itself did not develop properly. Okay. Then we have more questions. Can gastroschisis occur late in pregnancy? Truly speaking, no. But it could have been very, very small when you saw it at 20 weeks or 19 weeks and might have become much larger afterwards. So if I were referred a case as an expert and someone says, look, here is somebody where this has happened, then I would say, oh, is that so? And then I'd say, okay, maybe it was too small to be picked up, or the fetal position was not right, and it's a treatable condition. And that is how an expert should be speaking. But technically speaking, gastroschisis does not occur late in pregnancy. Now, how to differentiate persistent cloaca single opening versus double opening by prenatal ultrasound? Sometimes you're lucky. You can find fluid collection that guide you. If you don't have fluid collections, you're stuck. Okay, then there is this very, very wonderful question which says, do you get superior genetic material by a chorion villus sampling or by products of conception in pregnancies? And or is amniocentesis the best for a microarray? Let's look at them one by one. Products of conception will never give you a karyotype, so you'll miss out on translocations. Products of conception can never be free of contamination, almost never, and they will rarely therefore give you a standard conventional karyotype because the culture will be contaminated. So an antenatal diagnosis is much better than a post-abortal diagnosis. In an antenatal diagnosis, I have a choice between chorion villus sampling and a amniocentesis. Because I'm comfortable with both and maybe doing them for so many years, I would choose either, but I would tell my patient, look, theoretically speaking, the chorion villus tells me the DNA of the placenta. The amniotic fluid almost always tells me the DNA of the fetus, and therefore, would you like to wait? The world is shifting to CVS, yes, but the fact remains that placental mosaicism remains a reality, and we pretend it does not exist, and it does. Very often we come across an NGS that we do, like a gene panel for instance, on a chorion villus sampling, and then we realize when we did a Sanger on the amniotic fluid, because the patient wanted a confirmation anyway, it wasn't there. So when you understand genetics, you will realize that an amniocentesis remains the gold standard. An amniocentesis per se in individuals with newly acquired skin is much safer. And an amniocentesis gives you a good chance of actually looking carefully at the fetus at the 16-week window before you do the procedure. So I prefer an amniocentesis, although I'm equally comfortable with either a transabdominal or a transvaginal chorion villus sampling because that's the way I've grown up in the last 40 years. And I've been doing amniocentesis since 1984, and we've been doing chorion villus sampling since 1985. So it's truly something that I'm comfortable with, but I still do understand that I am far more comfortable because when I do a CVS and I'm waiting for a microarray, I'm still pushing my 12 weeks to 14 weeks. And believe me, at 14 weeks, the uterus is so inert that it is fairly difficult to induce, and you invariably end up with a lot more instrumentation during the termination of pregnancy. And that is a practical point. Not that I'm an obstetrician, but the fact is when you watch these procedures as you've grown and you realize what 14-week termination is like or 15-week termination, you realize that a 16 to 17 is truly much easier. And therefore you may as well wait. At 16 weeks, you still have a clean 4 weeks without too many hassles. And even after 20 weeks, you don't have too many hassles. Therefore, I invariably like to go in favor of an amnio. Although if the patient wants an early diagnosis, I will do a CVS and I will do it for their sake. And if the clinician says do a CVS and decide the case, I would go right ahead and do so too. Now, there's another interesting question on the significance of umbilical cord cysts and how to manage them. First trimester cysts are not so tough to handle. And they might be at the placental end, and they might be at the fetal end, or they might be in the middle of the cord. And the ones at the fetal end may be more sinister. Second trimester cysts are always more sinister. However, as a prognosis for urinary bladder obstruction, you will find that if you go back to your 12-week scan and you had an umbilical cord cyst, that is a reasonably good indicator of a poor outcome of renal function when you have an obstructed urinary system later in pregnancy. Therefore, I have now started looking differently at umbilical cord cysts. We used to ignore all of them in the first trimester anyway. Second one, isolated, second trimester umbilical cord cysts, largely ignored. But now we make a note of them because we know that Cartier-Balado and their group have shown us that the prognosis for renal function depends on this. It also, of course, depends on a thick nuchal translucency, and therefore we now make an importance to it. Next question. How is the urorectal septal malformation sequence different from an Oes complex? Yes, different names for the same thing. It's just the same wine in different bottles. The urorectal septal malformation may not have all the components. A pure urorectal septal malformation will have the imperfect anus, and it will have the extrophy, but it may not have the spine abnormality. And yet, it's just a question of semantics. It's just a question of language. Typically, when it involves the spine and there's no omphalocele, it becomes the entire Oes complex. And if it is less, then some people like to call it the actual urorectal septal malformation complex. Just different people calling the same thing differently. Now, is there a relationship between anterior abdominal wall defects and number of umbilical arteries or veins? We do see a single umbilical artery more frequently in anterior abdominal wall defects, but it's not that it makes the prognosis any better or any worse. And then it says, what is the cutoff of umbilical vein varix? I said we have a whole talk on it. Some people say 9, some say 11. I firmly feel that there is a length and a width to it. Which is the best book to read for all of this? I wish there was. I wish there was one book that I could read and say, okay, now I've learned it all. We need to read all the time. And we need to look at articles. We need to work with our peers like you and me, and I learn from you, you learn from me, and so on. But a book that I find truly useful for malformations and understanding them, and a book that's not too long and not going to take me the whole night to read a section, is Dario Palladini's book. It's old, it's now 5-6 years old, and there's a new edition coming out next year. But I still find that Dario Palladini's book called Congenital Malformations of the Fetus is an excellent reference for an overall view. It really works out well. Does omphalocele get associated with fetal ascites? Yes, we mentioned that. You could have an omphalocele with fetal ascites, and you could have a loculated or a free ascites, and you could have a umbilical cord cyst also masquerading as ascites because it's so close to the cover of the omphalocele. Can meconium be seen in amniotic fluid antenatally? Not related immediately to this, but the fact is that a meconium can be seen as echogenic flakes in amniotic fluid, but you could also find normal echogenic flakes, particularly at term where you find vernix, and blood and pus can give you the same appearance. So there's no specific appearance for meconium in amniotic fluid. Then we have, we really have a lot of questions tonight. What is CRL to describe hernia as physiological hernia? I like to use 64 millimeters. Some people like to use the 11-week 0-day business of 45 millimeters. I am far more comfortable to wait until 12 weeks 0 days or about 64 millimeters of ground rump length. Bijoy Balakrishnan really liked the flow chart. Thank you, Bijoy. That's very kind of you. How do you differentiate between a ruptured omphalocele from a gastroschisis? Very difficult, because the cord gets distorted and gastroschisis then can masquerade one as the other. Typically in a gastroschisis, you will rarely find liver. If you find liver, then you know it's a ruptured omphalocele. Then, of course, there is this question of risk of laceration. Is there any possibility that the next pregnancy will have the same issue for omphalocele, gastroschisis, etc., etc.? Gastroschisis, no. Risk of recurrence, very, very low. Omphalocele, yes. Risk of recurrence depends, like for instance, you have a Miledica, then you can get it. You have other causes which might repeat themselves, like some types of trisomy 21. You got to be careful. And therefore, it's better to be this. Then there is a reference for umbilical cord cyst. Again, we finished with that. How do I counsel Bodystock anomaly? Like we said, a very poor prognosis, extremely unlikely that this fetus will survive. If you wish to carry on for personal reasons or for religious reasons, it's your choice, but I'm not promising you anything as the outcome of this pregnancy. Can gastroschisis ever have a covering or a membrane? When we see gastroschisis, we often feel that I might have a sheet of something floating around. And then you start wondering what it is. Very, very occasionally, sheets of mesentery can actually come out with the bowel and look exactly like that. When you look at them at one single angle. Otherwise, you see it as mesentery and you recognize that. Also, you find a stringy line looking exactly like a membrane or like a covering, but truly speaking, its bowel that was originally dilated had surrounded a section of the gastroschisis and then went into infarction and atrophy and now looks as a covering membrane, pseudo covering membrane, so to say. So serial evaluation would be the best way to differentiate that. Size criteria for normal cord length. There's only one time that you can find the cord length, and that is at 10 weeks of gestation, where it is equal to the crown rump length. And routinely, we don't do scans at 10 weeks of gestation. So therefore, we really don't have anything normative for the cord length. And then, I think it's getting late at night. How to say that the cord insertion is slightly low? You look at the abdomen and you try and see how much of the anterior abdominal wall in the mid-sagittal is above, which is where do I actually see the heart and the lungs, and how much of it is below, and you will find out then on whether the cord insertion is generally low or high. If you find that there's very little distance between the cord insertion to the symphysis pubis area, then you're happy and be very pleased. And you see my diagnosis is made. But sometimes it can be tricky. There's no actual measurement that I can use. Now, only bowel but covered with membranes are still an omphalocele. Does this need karyotype? Every omphalocele needs genetic evaluation, not by a conventional karyotype, but because of the association with microduplications, microdeletions, and tetrasomy, I would always do a microarray when I see an omphalocele, provided my patient is willing to get it done. The choice of course, doing a genetic test is always patient-based. A word about regarding umbilical cord ulcer as a cause of recurrent fetal demise. Suggested reason, but we often feel that the ulceration of the cord was a result of ischemia rather than the cause of ischemia, and therefore we don't attach much importance to it. We don't understand this condition as well as we should at the moment, and I promise to keep you updated if I ever hear about it. We have your email here, and so we have an answer. Then there is a question here. Is the K angle altered in cloacal exstrophy also? Yes. In a lot of the so bizarre forms of cloacal exstrophy, you have a widening of the K angle, but most of the time the vascular anatomy in that region is so distorted that I truly don't even pick up the umbilical arteries beyond the portion near the upper part of the abdominal wall, and therefore I'm not able to get a K angle. If I'm able to see it, I know it will be wider, but then cloacal exstrophy is how much? We see like one case in 2 years in a tertiary center. It's not really too common a condition. So, but whenever we've looked for it, we found that umbilical intra-abdominal umbilical cord anatomy is fairly distorted in a cloacal exstrophy. Now, this is an interesting question. In one case recently, Dr. Vedya has seen a pentalogial contrail with one large cystic structure apart from the fundic bubble and separate from the gallbladder, with lower bowel loop separately seen, and everything. Could this be mesenteric cyst? Theoretically, yes, but more often these are ascitic loculations between the pericardial sac and the peritoneal sac, and these can be seen as loculations, as I showed in one of my cases. Then we have Dr. Harsh Arun asking me about microarray 315 or 750. Always a 750, please. Nothing less, and you don't need anything more. Then there is how does 3-vessel cord look in bladder exstrophy? In bladder exstrophy, you will actually find the cord on the outer portion. So it's like for single umbilical artery, you'll find one side. 2 umbilical arteries, you'll find both sides. Then there is this question of finding, differentiating a cord cyst from an omphalomesenteric cyst. Lots of descriptions in literature. I have never labeled an omphalomesenteric cyst in my life. I just call them all umbilical cord cysts because I truly don't know whether we can make that subtle differentiation. Can we give a trial of labor if diagnosed with omphalocele? Your pediatric surgeon will throw a fit. A, he doesn't like to wait for a vaginal delivery. B, he likes to be there. And for that reason, but technically speaking, you could give a trial of labor. Some patients might want a trial of labor. And it can be attended to after it's born. We find very nice cling film these days, surgical cling film, in which all this can be put and the fetus can be operated. Sometimes, if you have a small Fatates fetus, where we may not be repairing the omphalocele because the neonatal weight is too low for a safe anesthesia, in that case, it is wiser to do a delivery by cesarean section, reduce the chances of the omphalocele bursting, and therefore you'll then be able to carry on and do your omphalocele repair much later, particularly with small omphaloceles and small babies. But the moment you see a small baby, remember that again it could be a syndrome with growth restriction and omphalocele. So if you haven't yet already done a genetic evaluation, do it later in pregnancy and try and get your answer. So that brings us to the end of questions, and I hope I've answered all of them. And we're looking at putting a lot of these Society of Fetal Medicine webinars on either a YouTube channel or at a connection on our website. And we hope with the help of our trade partners, we shall be able to repeat these more frequently and make them continuously available. Thank you indeed for your attention, and my greetings once again from the Society of Fetal Medicine that has brought GE, VC Now, and all of us together for this webinar. Thank you indeed.
Thank you very much, sir, for your talk today. It was really, really informative and elaborative, and I really appreciate how patiently you have answered all the questions. And I'm sure this is a long list of questions you have got it today.
Yes.
And I'm sure our viewers would have got many take-home points from today's talk. And a special words of thanks to all the viewers joined today. Thanks, everyone. Thank you very much.
Good night.
Right.